Video of me actually putting in the screw. So you can see the patient's on their side. I already put my spacer in to basically take the pressure off of the spinal canal and help that area fuse. And then the screws are going, and the robotic arm is actually going in specifically the direction I want it to go. And then I put the screw, I go through the robotic arm to put the screw into the spine. And it's very precise, it's very accurate. And so last week I completed 19 surgeries on call. In this video today, I'm gonna walk you guys through some of those cases and let you know how my call went. What's up everyone, this is Dr. Webb here. Thank you for watching this video. Make sure you subscribe. New videos coming every week. You don't wanna miss them. For those that are new to the channel, welcome. I'm an orthopedic surgeon here in San Antonio, Texas. I focus mostly on spine surgery. I'm fellowship trained in spine surgery, but I also do take general orthopedic trauma call. Last week was an extremely busy week. I got pretty slammed with trauma cases and also a lot of elective cases. And in this video, we're going to talk about some of those cases. I'll talk to you and walk through you how I approach these surgeries, a little bit about the details of the surgery, but the specifics, whether it's male or female, whether the patient's age or their x-ray images or just images that I found online. I tried to be as specific as possible in terms of what's most resembles what the patient had and also what their post-operative images are. So these are not the real patient's images. I changed the history a lot for patient privacy, but you guys enjoyed the last video. We're going to jump into this one. So this is a list of essentially the cases that I did last week. I actually did 19 of them. These are general orthopedic cases, trauma cases at the top, and also some elective cases at the bottom, spine cases that I did. But we're gonna go through a couple of these and just talk about them. So the first consult that I got was a 62-year-old male who presented to the emergency room after he tripped and fell at home. He presented with this femoral neck fracture. So when you look at these x-rays here, for the layperson, you may look and not even see a fracture, or you may see one and I'm like, man, you're a little bit better than some of the medical students or even residents and may miss this fracture here. So the type of fracture that this is called a valgus impacted femoral neck fracture. Just the direction of the fracture line and the way that the femoral neck sits. It's in valgus. And we talked to the patient about the different options, whether to undergo surgery or to not undergo surgery. And this patient elected, we both came together in agreement that this patient needed surgery. And you can see the fracture line here, a little bit more evident. I kind of drew it out for you in this yellow line right here. But in general, for a femoral neck fracture, it depends on their patient's age, their activity level, the surgeon's comfort level in terms of certain procedures. But in general, we can do a partial hip replacement, which is called a hemiarthroplasty, or a full hip replacement. So you may not think of patients who come into the ER and they break their hip and they're getting a full total hip replacement, but if they're high activity, if they have arthritis on both sides of the joint, then they may be a better candidate for a total hip replacement. And then patients who have really minimally displaced fractures in the femoral neck, especially a young patient, we try to what's called pin these, closed reduction percutaneous pinning. This is what the CRPP is. But there are lots of different types of fractures. The red right here is the intertrochanteric region. This is your greater troch. This is your lesser troch. This is the subtrochanteric region. And then this is the femoral neck region right here. You can have femoral head fractures that are treated so totally separate. But in general, for a femoral neck fracture, this is usually the options that we give to patients. If a patient has an intertrochanteric fracture, we treat it with a metal rod called a cephalomedullary nail. Or if they have a subtrochanteric fracture, most of these are treated with cephalomedullary nails or intramedullary rods. These are rods that go on the inside of the bone to stabilize it so they can get up and walk again. These are just some pictures of the closed reduction percutaneous pins. So these are pins that go on inside of the bone here and they stay in forever. And then this is the cephalomedullary rod here. So this is a long one that spans the entire portion of the femur here. These are some screws that basically stabilize the rod here. This is what it looks like, sort of, one of the systems when it's not inside the bone. And then this is what I elected to do for this gentleman. You know, we talked about a hip replacement with him. He was a little bit older and his activity level he wasn't really active. So, you know, I felt like this fracture could have been treated with a hemiarthroplasty, partial hip replacement, or this little blade system here that actually stabilizes the fracture. But, you know, the downside of this could fail, which means he walks on it, it could fall apart. Then we have to do a hip replacement. But I felt like doing the least invasive option first. I wanted to get this gentleman into the OR quickly and off of the operating room table. He had some comorbidities, heart problems, pulmonary problems that we needed to do the surgery quickly. And this surgery probably took me, I don't know, 35 minutes or so, 30 minutes. And we were able to fix this fracture. This is what it looks like here. It comes with a little plate. So I actually put 2 screws down at the bottom here, and it has a bolt and then a screw that goes up to so it doesn't rotate. But this is a pretty common fracture, and if you ask 10 different orthopedic surgeons whether they're joints trained, which means they do a lot of hip replacements, or if they're trauma trained, you'll get probably 10 different answers in terms of how to fix these. But we'll follow this out for a few months and make sure it heals, and we'll go from there. The next patient consult that I got was a gentleman who fell from a roof. He came in with a really swollen leg. His leg was 2 to 3 size times the leg on the other side. And he had what are called fracture blisters. And these are these little blisters here, and they pop up because of the swelling. We don't do anything about this, but I find it funny that it freaks a lot of people out when they see all of these blisters here on the leg here. But those blisters just means that there's a lot of swelling. And when this happens, that means we can't do the definitive surgery, which would be a plate and some screws, until the swelling goes down. Just because when we try to close the wounds, it may be very challenging to do that if there's a lot of swelling, and can lead to a lot of problems. So what I did was a temporizing surgery. I went in and I put an external fixator. An external fixator is a device that holds the bone in place, and we sometimes leave it in place for 10 to 14 days until the swelling goes down, and then we can take the patient back to surgery to do the definitive surgery. You can see here the rods in the video that are attached to the bone, and my assistant is applying Kerlex around these pin sites to keep them clean. But this is a tibial plateau fracture. It's what it's called. There's a classification called the Schatzker classification, and on a scale of like 1 to 6, this is actually the worst type of fracture that you can get in terms of severity. But this patient, temporizing surgery, and then I won't do his definitive surgery. I'll send it to a trauma surgeon who does these all the time, that can fix him kind of at a later date once his swelling goes down. But this was a pretty cool case also. This is another picture of what it looks like, those metal rods here. These are bars. These pins here, they go inside the bone to hold it in place until the swelling goes down. So he will go home with this and just wear it until his definitive surgery, which can be anywhere between 7 to 10 to 14 days. But I've had some patients that didn't show up after this surgery. I put these rods in their leg, and I'm like, man, where'd this patient go? They never showed back up. And then you find this on eBay or something, these rods. So this is another picture of it. You can see these fracture blisters right here. The next patient was a gentleman, not the healthiest, or female, not the healthiest patient. She presented with shoulder pain, and she had an infection in her foot. She had an amputation before. She's uncontrolled diabetic. So the diagnosis was scapular osteomyelitis. I had never seen an infection inside the bone like this. That's what osteomyelitis is, infection inside the bone that needs to be taken to the operating room for most cases. If the patient is stable, sometimes we can just treat them with IV antibiotics. But this patient, it had infection in their bloodstream. The infectious disease doctors were wondering, like, why is this patient so sick? So I just decided to take him to the operating room for an IND, which is irrigation and debridement. And WVP means wound vac placement, which means I place a device over their skin to keep the wound nice and closed. And this is the scapular region here. The patient had an infection right back here in the infraspinatus, where this muscle sits, and they had infection in this bone right here. She did along the scapular spine. So I just made an incision right along the scapular spine right here, and when I elevated went under the infraspinatus, there's a big pocket of pus there. So I just washed it out, took some bone, sent it to the lab, and then give him IV antibiotics, and then hopefully that treats her infection. The next patient was a 76-year-old male who presented to the ED after a fall from standing. He was at home. He tripped on the rug and trying to chase his dog. X-rays show that a femoral neck fracture. So this goes back to what we talked about. For femoral neck fracture, we can talk about a partial hip replacement or a full hip replacement, which is called a total hip arthroplasty, or we can do a closed reduction percutaneous pinning. And for this gentleman, he was a little bit older, wasn't very active. You can see the significant displacement in the femoral neck here. So I didn't think pinning this or putting that blade system would actually help this. So I actually elected to proceed with a partial hip replacement, which is what I did. We are here about to do a hip replacement for a gentleman who came in with a hip fracture, femoral neck fracture. So I'll do a partial hip replacement. We wear these hoods here to protect all the bodily fluids from, touching our face, and we'll do a hip replacement. It should take about an hour or so, and then after that we move on to our next case. This is essentially where we cut the bone here, and the femoral neck is already broken. And then we put this metal or these titanium, sometimes cobalt chrome implants on the inside of the bone to replace it. So this is a partial hip replacement, meaning that we replace this portion of the socket here. We're not replacing the acetabulum, we're just replacing the ball and then the stem that goes inside the bone. This is a video of me actually reaming the canal. So before this stem goes inside the bone here, I actually have to prepare the canal, which means I stick a reamer and a broach, go inside the bone to create a cavity. And then I can put this implant in here. This is a picture of the femoral head right here. So after I cut that portion of the bone that's broken, I cut it right here. And then this portion has to come out. So I actually remove that with a couple different instruments. This is the femoral head that we remove, and then the patient gets a partial hip replacement. This is what it looks like. Again, this is not the patient's x-ray. This is a picture I found online, but this is a partial hip replacement that a patient can get up and walk again after surgery. This surgery took about an hour, and then I'll see him back in my office in about 2 weeks. The next patient was my elective surgery. This is a 62-year-old male who presented with neck and arm pain. The diagnosis is cervical stenosis, which is essentially it's narrowing, or there's less space for the spinal canal in the neck and the nerves, and patients can present with neck pain, arm pain, problems with their balance, their gaits, and I'll show you guys another case about a patient who presented with what's called cervical myelopathy, which is a dysfunction of the spinal cord. I proceeded with a cervical 3 to 5 anterior cervical discectomy infusion, which means we go through the front of the neck to do the surgery, which is one of my favorite surgeries to do. I love the anatomy. But cervical stenosis, when the spinal canal is too small for the spinal cord or nerve roots, This can cause damage to the spinal cord or nerves. You can see here the pinching of the spinal cord from all this compression here and all the bone spurs. A couple of different ways we can approach this, actually 2 ways. Anterior cervical, posterior cervical in terms of your approach. And there's pros and cons to going through the back of the neck or the front of the neck, but it's usually sometimes surgeon's preference, or if the patient's anatomy kind of precludes going through the front or through the back. This is the patient laying on their back, and then I go through and move the esophagus and trachea, just gently move that out of the way. And then I move the carotid sheath and the carotid artery to the lateral side, and then get down to the disc, remove it with a knife and some instruments, and then place a plate and some screws to stabilize this area here. You can see the plate here. It's another view of the plate and screws, and then this is the spacer. So when we remove all this diseased disc here, we have to replace it with something. This is usually a metal or titanium or a PEEK or plastic cage that goes into this area to help it fuse together. The next case was an elective case, gentleman who had cervical myelopathy, which is a dysfunction of the spinal cord. So a lot of these patients will present with loss of balance, their gait, they have clumsiness in their hands, so I ask them to squeeze and open their hands really fast. They can't do that. I'll have them walk and their balance, their gait is kind of off, or they're dropping things out of their hands, really bad neck pain, or they may have some arm pain also. So these patients, we try to get to them as soon as possible. So as soon as we can, because this can actually get worse. So this patient, I did a cervical 3 to 7 posterior cervical laminectomy and fusion. He was dropping things out of his hands. He had weakness. He had gait instability, which means his balance was off. The patient is positioned in the prone position. We tape their shoulders down like this here so that we can actually see what we're doing with the x-ray. And they're face down. They have a tube in to help them breathe. They're in surgery. This is what it looks like after we make the incision. You can see the cervical vertebrae here, and then we put our screws and rods through each portion here, and then we take the pressure off this whole area here to make more space for the spinal canal and spinal cord. This is a picture that I found online, what it looks like. Obviously, I didn't do this many levels, but you can see these screws here and the rods, and then the lateral position, lateral x-ray, you can see the screws going nice and perfectly into the bone here. The next patient is a patient that had what's called spondylolisthesis, which is a slippage of their vertebrae. She had really bad back pain, and also she had really bad, 38-year-old male, really bad leg pain. So the diagnosis was spinal stenosis, and then my procedure was a lateral interbody fusion with pedicle screws. And this was a case that, I did a lot in training. I've done some in fellowship, but I've never done it where I put the screws in while the patient's laying on their side. So it's called a single position lateral interbody fusion. I use actually the robot for this, so it was robotic assisted. And usually what we'll do is we'll have the patient on their side, and then we'll flip the patient on their belly afterwards to put the screws in. But given this, I decided, hey, I want to try doing this everything from the side. So leave the patient in the lateral position, or put their screws in with the robot while the patient's laying in on their side. And the idea behind this is that hopefully it saves time. The workflow has to be really kind of on point. And after I do a number of these, I'll get quicker in terms of my efficiency and also workflow. So the first case could have been a lot better in terms of the workflow, but you have to do a lot of procedures and surgeries to be really routine and kind of get your workflow down. A couple different ways you can actually approach the spine. We can go through the side, we can go through the front here called an A-lift, we can go through the back called a T-lift, or the PLIF is going directly from the back. So this is the patient laying on their side here. You can see my incision is actually 2 to 3 centimeters, and I draw this line here so that x-ray can line up and go directly in line with my incision here. And then this is a video of me actually putting in the screw. So you can see the patients on their side. I already put my spacer in to basically take the pressure off of the spinal canal and help that area fuse. And then the screws are going, and the robotic arm is actually going in specifically the direction I want it to go. And then I put this screw, I go through the robotic arm to put the screw into the spine. And it's very precise, it's very accurate. And this is the reason why I think robotic surgery has a role in spine surgery. These are just pictures of me putting in the cage here. You can see I'm using a mallet, putting a spacer in through this little tube here. And then this is the robotic arm here. So I can actually tell the robot to go to the left side of, let's say, L4, and the robotic arm will move zing, exactly where I want it to go, and I just drill. Make an incision, drill through the bone, put the screw in. Very precise, very efficient if you have a workflow that's really down. These are just a picture I found online. This is similar to what it looks like, a one-level lateral. You see the screws and rods here and the spacer kind of to take the pressure off of the spinal elements, which are the nerve roots, which are right back here. So this is how my week went. So there are a couple other cases that I did, infection cases that I was on call. Patients who have infection after surgery, we have to take them back to wash them out and make sure we get rid of all the infection. A couple other trauma surgeries and also some elective procedures, but man, that was a very long week. I'm exhausted, but I had a lot of fun, and I hope you guys enjoyed this video. If you guys want more of these, please let me know and I'll try to do more, but this is how my week went last week on call. This is Dr. Webb. We'll see you next time.